Good morning, good morning, good morning, good morning. Welcome to another session of our continuing medical education. Today, we have a wonderful presentation lined up for you. I am most certain it will be very exciting, and you will learn a lot to elevate your knowledge and be the best that you can be in the healthcare industry. Before we begin, let us close our eyes and have a word of prayer. God in heaven, we come before you this morning, thanking you for another day. We pray, oh God, that as we are about to commence this session, we pray that you be with our speaker, and we pray that you be with each of us, that you would open our minds to help us to receive that which he has prepared for us. Be with us, guide us, protect us. This we pray in no other name but the name of your Son, Jesus Christ. Amen. Okay, so let's get ready to go. For those of you who have not had the pleasure of meeting our speaker, it is my honor to introduce her to you. Our speaker today is Autira Newbold. She is a seasoned physiotherapist and a dedicated advocate for patients and public health. With a robust background in spearheading multidisciplinary collaborations, she has successfully piloted initiatives integrating specialist physiotherapy into public, primary, and tertiary care settings. Her extensive experience includes presenting at prestigious conferences like the World Confederation of Physiotherapists, Leadership Forum, the Caribbean Association of Orthopedic Surgeons, and the Sandilands Rehabilitation Center Geriatrics Symposium. Currently, serving as the president of the Bahamas Association of Physiotherapists and as the Bahamas co-representative at the North American Caribbean region of WCPT, Autira brings a wealth of knowledge and leadership to the forefront of healthcare. Her academic credentials include a Bachelor's of Science in Physical Therapy from Florida International University, a residency in neurological rehabilitation, PNF, a postgraduate certificate in wellness, fitness, and health. She's also on track to complete her transitional doctorate in physical therapy by December of 2024. Autira's diverse practice and personal experiences have shaped her philosophy on healthcare, emphasizing the importance of co-designing care with patients, promoting person-centered care, shared decision-making, evidence-informed practices, and encouraging individuals to embrace their rights and responsibilities in achieving positive mobility outcomes. So please welcome with me our presenter today, who is presenting on the role of physiotherapy in addressing lower back pain, Ms. Autira Newbold. Go ahead and unmute for me, Ms. Newbold.
Okay,
There we go.
great. Wouldn't be technology if I didn't have a moment. So thank you very much for allowing me to come. Hold on 1 minute. I'm at work, so anything seems liable to happen. Thank you again for allowing me to come here this morning to present the role of physiotherapy in addressing low back pain. It is my hope that through this presentation, you will be able to see how physiotherapists play an important and a much needed role in patient care, as well as be able to understand how we can all work together for the eventual outcome of our patients. As far as some highlights, I currently have specialties in orthopedic and musculoskeletal physiotherapy, as well as neurorehabilitation and spine care. The highlights as far as my presentation journey would have been previously mentioned, having had the opportunity to present at the Orthopedic Symposium, the Caribbean Orthopedic Association on the topic of specialist physiotherapists in an orthopedic clinic, at the Bahamas Association Physiotherapy Month, presenting on physio being more than just massage, and at the World Confederation of Physiotherapy Leadership Symposium on interdisciplinary connections and collaborations, an advocacy project. I would also like to disclose that I'm also a patient. So not only am I a provider motivated to assist my patients to get the best outcomes, I'm also a patient where there's a level of empathy that I have the ability to communicate with patients on a level of understanding. So just a little pre-test for you to, I know it's a Friday morning, but some things that I want you to be able to keep in mind as we go through the presentation today. What are the key red flags in low back pain that warrant an urgent referral to a specialist? List at least 2 evidence-based physiotherapy interventions for managing chronic low back pain. And what is the role of physiotherapy in post-operative rehabilitation for patients who have undergone spinal surgery? The objectives that we're going to cover today will be an introduction to physiotherapy, as far as the length, depth, and breadth of the profession and some of the progress we've made, the problem as far as the incidence of low back pain, PT's role in being a provider and a solution for persons with low back pain, some global evidence-based recommendations that we may have from WHO as well as other entities, some next steps in being able to implement a more interdisciplinary approach to care management for patients experiencing pain, and then some general housekeeping for ourselves within our facility to be able to communicate between ourselves in a more clear and deliberate manner. Who are we? The WCP defines physiotherapies as a healthcare provider who, I will only read the bold points because those are the real bullets and meats and potatoes of what physiotherapy is. We focus on maximizing movement and functional ability at any stage of life. So essentially from the cradle to the grave. And our goal is to maximize quality of life for our patients. Our scope of services: we are HPC licensed and regulated professionals who seek to develop, restore, maintain maximal movement and function across the lifespan. We employ therapeutic interventions to maximize client quality of life, collaborate with healthcare teams. Much like medicine, we also have specialties of practice that include musculoskeletal and orthopedics, cardiopulmonary, women's health, incontinence and pregnancy, oncology, electrophysiology, pediatrics, neurology, geriatric management. In the US, they have board certification. In the UK and other systems that may have a more universal healthcare model, they gain their specialty practice from actually advancing within the practice, not necessarily a board certification. Some of the treatment methods we may employ may include what's on this slide, but it's not limited to that, as far as our ability to assess and reassess, developing plans of care, patient and caregiver education, being a care liaison, using modalities such as electrotherapy, thermal modalities, using manual therapy, using instruments. You may have seen the colorful taping at the Olympics and other sporting events, kinesio taping. We're involved in cardiac rehabilitation. We help to mobilize patients as far as gait, the way that they walk, and ambulation, their level of independence in their ability to walk. We're also involved in ADL transfers as far as the functional capacity that is required for someone to stand up and be able to put on a pant one leg at a time, or to get from a bed to the chair in an actual task. Not necessarily like it may be on the ward where there's just the routine transfer of a patient from bed to chair. Nutrition advice, stretching, range of motion. We are involved in neurological rehabilitation. And as you may be aware, the PHA has acquired the Evolve facility. We will be offering aquatic therapy at that time. On the topic of low back pain, the statistics state in 2020, 619 million people suffered from low back pain, and this number is expected to increase. At this time, low back pain is the leading health condition requiring rehabilitation services in 134 of 204 countries. So thus the impact of that causes a high burden of 568 million people, which equates to about 64 million years lived with a disability. And it is the main cause of premature exit from the workforce. It has a higher prevalence in low income and middle income countries like the Bahamas. It has an economic burden. Just to show a snapshot, in Brazil, it accounted for 100 days absent from work per person per year at a cost of about 2.2 billion. In the UK, it cost the NHS, Universal Healthcare System, nearly 5 billion annually. And in the US, the cost for low back and neck pain reached about 134 million in 2016. Workforce impacts. It has a high prevalence in working age people and can lead to absenteeism, decreased productivity, and early retirement. Low back pain disability has increased in all age groups from 1990 to 2019, with the highest impact between those that are 50 to 54. 5 facts on low back pain. Again, leading cause of disability globally. Most cases of low back pain are not specific, which means that there is not a pinpoint cause or reason for a person to have low back pain that can be easily identified. Physiotherapy has been established as an effective solution for low back pain. One may be aware that scans aren't always necessary. That's inclusive of X-rays and MRIs for the management of back pain. In that you may have someone that has a really bad MRI but has no signs and symptoms, or X-ray, and then you may have someone that has insignificant symptoms, insignificant findings on an MRI or X-ray that has out-of-the-box pain complaints and disability complaints. Surgery is often not needed for low back pain. What is physiotherapy's role in low back pain? It is a non-invasive, cost-effective approach for the management of low back pain. Our primary goals with helping our patients is for pain relief, restoration of their function, improvement of their general mobility. We're also trying to prevent reoccurrence and to prevent them from having surgery. The method by which we may do this involves early intervention and prevention, assessment and screening, individualized exercise programs, pain management and modalities, patient education and self-management, a biopsychosocial approach, chronic low back pain and long-term management, post-surgical rehabilitation, return to work and functional training. When we talk about early intervention and prevention, we're looking at the fact that once someone has their first incident of low back pain, we would say that 90 to 95% of those persons, as we mentioned, non-specific, we're looking for that to resolve within about 6 weeks. So those patients, we're looking to arrest what may be certain anxieties and catastrophization of what they may have as this new experience of back pain, and to assist them with easing into activities of daily living without feeling threatened. We would look to manage them with modalities, education, and some simple advice and instruction and exercises. We're trying to prevent them from progressing along the continuum to the point of chronicity. A lot of patients at that stage may not necessarily be referred for physiotherapy, when ideally they should be referred for physiotherapy, if only again just to arrest that progression from acute to chronic. In our investigations and assessments, we take note of the causes of low back pain. While there may be non-specific causes, there are certain conditions that affect the treatment option that we decide for patients. So with our comprehensive evaluation and our knowledge that most back pain is mechanical or musculoskeletal, involving strains of muscles, sprains of the joint complexes, damage or some kind of injury to the intervertebral disc, the facets, the SI joint, stenosis either in the foramina or within the cord, the spinal cord itself, being sensitive to spondylolisthesis, we would look to be aware of that and adjust our management accordingly, looking at degeneration, osteoarthritis, degenerative disc, degenerative joint disease. We also need to be sensitive to the non-mechanical causes of low back pain. These require additional testing, and they may include things like infections, cancer, inflammatory disease. Neurologically, we are sensitive to sciatic, lumbar radiculopathy, and cauda equina. And looking at trauma, we have a number of slip and falls. We have a number of occupational injuries. We have a number of car accidents, a number of hit and runs. And also being aware of referred pain, the fact that a patient's presentation of back pain could be coming from somewhere else, albeit the kidneys or possibly something more sinister like an aortic aneurysm, where they may feel some palpation, pulsating in the abdomen. In our assessment, we may use outcome measures such as the START back tool, which has been shown to be used as a prognostic indicator for decision making concerning which pathways do we want to choose for treating patients. The areas to be assessed include a gamut of activities of daily living, depression, functional mobility, gait, general health, life participation, mental health, pain, and quality of life. On the tool, which can be acquired on the internet or at the Keel website, you have questions in which you're looking at trying to stratify patients into either a low or medium risk category that then gives you an idea of management and, like I mentioned, prognosis for this patient as into how long their particular care journey may be. And so based on their outcome from this tool, when we stratify them, we plan their care to say, let's say a low risk patient may be advice and instruction and may be able to suffice with home management. A medium risk patient may have to come in and get therapy. A higher risk patient may have a longer term than is normal than a 6 weeks or even potentially 3 months. But it also allows the patient to be aware that there's this stratification going on so that they can appropriately manage their respective expectations. As far as for the lumbar, we also use outcome measures as far as the Oswestry Disability Index to assess symptoms and severity of low back pain as it relates to disablement and the degree to which the back or the leg pain is actually impacting their functional activities. Some of the areas assessed are similar to the ones for the Start Back tool, but then you also see that it includes gait, it includes the subcategories of social relationships, sleep, self-efficacy, sleeping, occupational performance, and life participation. The Oswestry has a similar scoring where it gives you a percent level of disability with the patient answering the questions in sections 1 through 10 as far as pain intensity, covering categories as far as pain intensity, personal care, lifting, walking, sitting, standing, sleeping, traveling, their social life, and actually even sex. Oftentimes, we don't have those conversations with patients. Some patients are open enough to share those challenges, especially when you have a couple where one is plagued with low back pain and have an inability to consummate and engage in intimate relations. This form allows them to discreetly note the level of disability that they have in that area and allow you to broach the subject for conversation to see what we can be able to do to assist them. Important in our screening with our patients is looking out for red flags as far as cardiac equina, trauma, unexplained weight loss, those with a history of cancer, fever or infection, progressive neurological signs and symptoms. While age may not seem like a red flag, we wouldn't traditionally expect incapacitating low back pain in someone who's under 20 or someone over 50 who may previously not have complained about it. Those who have prolonged steroid use, we may have a number of patients who have chronic kidney disease that are at risk for things like pathological fractures that we need to appropriately screen for. Those who may have had a term of physiotherapy and show no demonstrable gain or progress from that conservative care. And then there are those that have night pain or pain at rest. For physiotherapy, we see patients with an individualized exercise program, which is one of the strongest treatment methods that we have in physiotherapy. And this method employs a more active approach. We use strengthening and flexibility. Now, all exercises are not equal. I know when we started in the orthopedic clinic, where we currently have a physio in clinic for every orthopedic day, that previously they used to routinely have a handout printed that any back patient, they would give them this handout. But with all exercises not being equal, if you have a patient who is stenotic and potentially has what we call a flexion bias, in that they have a preference for flexed, bent over positions because that position allows them to open up their facets and minimize the pressure, then having them do a prone cobra may be counterproductive, and that patient may come back complaining about a significant amount of pain. Equally, if you have a patient that is having a discal pathology that tends to be more extension bias, preferring positions, let's say standing, walking, having that person do what some may call Williams flexion exercises, where they may be in a supine position with their hands and knees touching and rotating and bending and curling up, may provoke their particular symptoms. Equally, if you have someone that has a spinal instability where they are a mixed bag between flexion and extension. They may complain of things like feeling a cracking or a popping, or just a sense of movement, or unstable. Those patients require more isometric core contractions and control and stabilization exercises for the small muscles in their spine. So that would have been an idea of how we potentially classify our patients on an individual exercised approach. We also seek to restore mobility. When patients go through a period of low back pain, we know that there may be spasm and the muscles may become very tight and rigid. We then have to reintroduce movement, reintroduce the normal extension in someone who's stenotic, reintroduce flexion at some point in the subacute to stages going further along in someone who is having a disc pathology. Introduce some rotation in someone who is unstable in having that spinal instability. Pain management and modalities. Now, this is the area where most patients love. Why? Because they don't have to do any work. It's a passive modality. So it's a means by which something is happening to the patient. So this may include things like manual therapy, where they want a massage. We may do mobilizations. And for those advanced practice physios, they may do manipulations at particular segments or joints. Unlike chiropractic, the manipulations are not done as a routine practice, but is actually done based upon the assessment of the area and the need for a release of that area to instill some movement and motion. So every session of manipulation or mobilization may not be done because it's based on continuous assessment from one treatment session to the next, as well as the patient's subjective reports of it being of benefit. Manual therapy may also look like someone using an instrument to assist with mobilizing the tissues as well. You may have seen some metal instruments that persons may scrape across the skin that assist with mobilizing the tissue. Modalities may include the thermal modalities like hot packs and cold packs. You may use ultrasound in either a pulsed or continuous mode, pulse being that the signal in the ultrasound is interrupted, so it's not continuous. We may use electrotherapy, things called like interferential TENS therapy, and several other modalities along that path. So a patient would just have to lay down or sit or whatever is their particular position of comfort to have these modalities on them. We employ patient education and self-management, where when we're getting to the point of looking at patients returning back to work, or we're looking at patients' workstations, let's say you have someone who may be an office worker, we want to look at how their particular station may be set up. We have a lot of people now that are using their laptops on their desk, which may position them with a more forward and rounded head and posture. You may have heard before that sitting is considered the smoking of our generation. The real crux of that situation isn't necessarily that sitting is considered the smoking of our generation, but the fact of what sitting represents in physical inactivity. And so, with more remote work and persons having more sitting or static times, they're becoming more inactive, and they're in positions that have them relatively flexed and in poor postures for a prolonged period of times without pattern interruption. So oftentimes we'll say to patients to avoid sitting longer than 30 to 45 minutes at a time without getting up to get a cup of water, going to the restroom, getting a file, saying hello to a coworker, because sitting for a prolonged period of time fosters again that act of physical inactivity. And when we hear about posture, everyone has their own unique posture. The idea of the military chest lifted, abs engaged, stand up tall may be okay for one person, and for another person, that might not be okay. So we accept persons for their relative postures, but we also try to improve upon that posture if we can foresee it being a challenge, if they are, again, in these occupations where we know that they're less active and we know the pressures and the increased stresses that can be placed on their disc and their supportive structures. So along that vein, we would teach patients self-management technique and strategies. We would give them handouts that might show them a proper workstation setup. As I mentioned, we may have them employ things like timers that allow them to get up after the 30 to 45 minutes so that they can interrupt the static sitting and get some movement. We may advise them to possibly purchase a sit to stand desk where they have the ability to alternate and not break the flow of their working with using a sit to stand desk. We may have persons, like how I'm using a headset, purchase a headset as opposed to bringing the receiver for the phone to their head if they are someone that works front facing, forward facing, and takes a lot of calls. We may also ask them to purchase things like hot pack, cold pack, for what we know if their particular condition may be more degenerative, where we know that the likelihood of episodic reflares or reoccurrence may happen, that they have the ability within their own capacity to, and at home, to be able to treat themselves, assist themselves, and have a certain level of self efficacy and ownership over them being able to help themselves. The biopsychosocial approach in the recent years, especially in persons with pain, we've realized that there is a strong psycho, emotional, and social component when it comes to pain. I would dare say in more than 50% of the patients that I treat, there are a lot of social determinants, there's a lot of psychological determinants, and there's a lot of emotional determinants. Because while this may not at this time be a permanent change in role, it is a pattern interruption for what their life has been. And so for this person, the idea of being unable to get a good night's sleep, and we know what sleep does for the body with regards to recovery for the next day and quality and peace of mind and general irritability, when we look at what someone's inability to work because of pain does, especially if they are potentially a contract worker or an independent contract where if they don't work, they don't get paid. So then their bills are piling up and all these different things are happening with them. Or they have dependents that they need to pay school fees. All these things come into the picture when we treat the patient and we look at them from a holistic point of view. Because when those patients come to us, all of that comes in what is considered their pain experience. And we have to filter through that, respect that, honor that, and address that as we also treat the physical dysfunction that the patient is coming to us for. Chronic low back pain and long-term management. So for those patients where it does progress to the point of chronicity, the best strategy for them is a multidisciplinary approach that may potentially include a pain management program, a referral to a pain specialist where they may get injections, whether it is epidurals, um, whether we may also refer them to a psychologist, where our efforts in mitigating anxiety may have failed at the rudimentary level. They may require a bit more advanced intervention. And also having a communication with their doctor as to whether or not this is someone that may progress to the point of surgery, or whether this is someone that we recognize that their biopsychosocial issues are much stronger than their physical issues. So then, as care providers, we then need to be sensitive to the language and the wording of our communications with patients, because we know that those particular patients may be more skewed to the negative of whatever we say, as opposed to what we know to be the opportunities for progress for that patient. We look for disability reduction through encouraging functional movement. There may be those patients that have pain that every day may be painful. But for them, a good day is having a 2/10 as opposed to a 7/10. And coaching those patients along to understand that they now have a lived experience of pain, and that they have to accept, as I mentioned before, manage expectations of, we're not looking for pain-free. We're looking for your quality of life and what you have the capacity to accept in being able to be functional, being able to show up for your life and living, being able to provide for yourself, being able to be gainfully employed. If we were in those types of patients to chase pain-free, neither one of us would win. We have a role in post-surgical rehabilitation. With patients that have had surgery, communication with their surgeon is a must, because we need clarity on what was done. We need clarity as it relates to this person's potential prognosis with regards to what is the expected end for this patient. Because we do know that certain procedures, even before you do the procedure, may have a certain success rate of 60%. And because the decision may have been made to minimize any progression of, let's say, a neurological compromise, the odds were taken. But the patient may have interpreted this as, oh, my problem is going to be solved. And so as time passes and their expectation, and there's a mismatch between their expectation of going back to prior level of function with no problems, no issues, and the reality that they may have a lingering disability, that level of conversation needs to be happen between the surgeon and the physiotherapist, because we spend more time with the patient in a care plan than the surgeon on the alternate visits. So some surgeries for the lumbar may include spinal fusions, laminectomy, where they may remove bone, discectomy, decompression, laminoplasty, where they may open up the space for the lamina, and spinal stenosis surgery. So just to have an idea of the general anatomy, when I was talking about laminectomy and laminoplasty, as well as when we talk about for spinal stenosis being as far as central stenosis in this region and foraminal stenosis in this region. Previously, when we talked about spondylolisthesis, it would look like one vertebra slipping forward off of the other vertebra, and thus interfering with what would be the natural alignment of the lumbar spine. When we've progressed patients along that point, that we're now looking at performance. So for those with a low level, it may be prevention of progression into chronicity. For those in physiotherapy, it may be maintaining, or again, progressing, preventing it from going to the point of chronicity. The end goal is to get people back to work, get people back to function, or get people back to performance or sport in those cases where you have a lot of community-based
Hey, good morning, Dr. Holiday.
things for persons, like those people who enjoy basketball. They have a regular tennis match. They have regular golf. This is truly a part of their life and living. I know I had a patient who had a routine that almost every walkathon that happens on the weekend, there was an expectation for him to be able to sign up and go through that. So that was his goal, even though he was retired. So part of work conditioning includes getting patients back to doing their jobs. So it requires a conversation of task analysis. What type of work do you do? What are the actual tasks involved in you being able to do that job, as far as bending, squatting, lifting, pushing, pulling, those types of activities? And let's say in the case of nurses, you may find yourself having to be bent over a bed, which means that you're flexed over a bed, potentially manipulating the load of a patient. So even more in those positions, because we know that the intradiscal pressure becomes very high, to be able to have a strong core and core control. The World Health Organization, as far as we mentioned, is in objectives, global evidence-based methods, and recommendation, recommends a patient-centered biopsychosocial approach and non-surgical interventions that may include, as I may have mentioned, education programs, exercise programs, physical therapy. Manual therapy was seen as a viable option. Psychological therapies, the use of cognitive behavioral therapy, and where applicable, non-steroidal anti-inflammatory medicines. Treatments that may not be recommended. Now, this for me deserves an asterisk, because while these treatments in isolation may not be recommended, things like traction have a use, I believe, at the certain stages of injury. So, for instance, this particular advice, as far as treatments not recommended, was communicated by the World Confederation of Physiotherapy in their advocacy for what was World PT Day, in the information sent out to member organizations. However, what I thought was lacking was the context of it. So one can say in absolute that these things should not be used. However, if one were to look at, again, the phase and stage of a particular injury, there is evidence for traction. There is evidence for bracing. There is evidence for a mindfulness-based stress reduction, which can be seen as a psychological approach for a patient in relaxation, in getting them out of their heads and into their bodies. So sometimes we have to look at certain recommendations with a grain of salt. And we do know that in the Bahamas, we have a significant level of obesity that is also tied to deconditioning, and that having an effective weight management program can be helpful for patients, in that losing weight also minimizes the amount of pressure on their respective joints and spine. Some case studies in Australia using a cognitive functional approach, which would have been a biopsychosocial approach, found cost savings and improved patient outcomes, and found patients returning to work with reduced disability. In the United Kingdom, with using the Start Back outcome measure, they found a positive impact and a significant return on investment of $226 for every $1 spent. And in the United States, early physiotherapy intervention found a net benefit of $4,160 per patient, including all hidden costs. Because of the role that the World Health Organization and other nonprofits have seen for physiotherapy in the management of low back pain, they found that there was a need to strengthen rehabilitation services worldwide, facilitating identification of and access to effective non-pharmacological interventions. We also know that pharmacological interventions have their own risk, albeit things like kidney and liver issues with the filtration. moving away from harmful low-value healthcare options such as opioids, because we understand the risk of addiction associated with that. From the World Health Organization in this 2030 initiative, they recognize rehabilitation as a fundamental element of disease management. They also would recommend that physiotherapy has a role in primary care, integrating into healthcare systems, strengthening rehabilitation at the primary care level, inclusion of physiotherapists and occupational therapists at the primary care level, patient-centered care with individualized care plans, and focus on long-term management and prevention of low back pain. Some of these strategies to implement the use of physiotherapists within the healthcare system that we currently have may include a better integration of physiotherapy services into the hospital, training and development of staff on the use of physiotherapy across the span of the different conditions and specialties, collaborative care models with other healthcare professionals, also improving our community outreach, education and awareness programs for patients, community-based rehabilitation services for those patients that may have those degenerative conditions that we know that there's going to become a period of time that they will have a flare, and they just need to get back on some level of regularity with exercises and management, because we know that oftentimes when patients feel better, they stop doing the exercises, when in truth, the same way for hypertension and diabetes that they are prescribed medications, that patients exercise is a prescription. The use of technology and innovation using telehealth, which we currently do use for patients on the Family Islands, where it's cost prohibitive to come to Nassau, and incorporation of digital tools and apps for patient self-management and education. Future directions in low back pain management, research and development, continued research into non-surgical and non-pharmacological, development of new physiotherapy techniques and tools, implementation of policy and advocacy for changes to have low back pain as a larger priority on the global health agenda. We would have all heard in the media about the Prime Minister having to go away for sciatica. The question then becomes, on those types of cases, never treating, not knowing intimately what his particular issue is, that when those types of conditions happen, that's where physio could have been seen early before it potentially got to the point of progressing. Collaboration with governments, payers, and healthcare to implement effective solutions, and patient education to promote self-management and prevention strategies, and look for accessible resources and materials for patients. In conclusion, there's a call to action: the growing epidemic of low back pain and its impact on society. Physiotherapy has been deemed an effective treatment and does have a critical role in the management of low back pain, but we need more integration into primary care and hospital healthcare systems. Currently, we are significantly and severely short-staffed. With the onboarding process, the applications of new applicants really not reaching the threshold that we need to meet the needs of the service that we currently employ. Collaboration among healthcare professionals, policymakers, payers, and the community. Prioritization of physiotherapy as a non-pharmacological and non-surgical intervention for low back pain. And commitment to improving patient outcomes and reducing the global burden of low back pain. So, on review, are you able to identify key red flags in low back pain that would warrant an urgent referral to a specialist? Can you list 2 evidence-based physiotherapy interventions for managing chronic low back pain? And are you aware of the role of physiotherapy in post-operative rehabilitation for patients who have undergone spine surgery? Now, just a housekeeping, for a referral or a consult to physiotherapy, just to be able to make sure that we're best serving the patients, we need to make sure that the referrals are clearly written and signed and dated as required by law. The information is complete and accurate of the patient's history. The patient is medically stable. Currently, we're a satellite facility without a physician or a nurse present at outpatient services. So, in a medical emergency, we have to call for emergency assistance like any other citizen in the Bahamas. The reason, and on the referral, we need the reason for the referral, the diagnosis, consult, take over care for this patient, or a specific procedure may have been done. Any summary of the patient's current status, date of injury, or surgery date. Were there any investigations done, such as x-rays or MRIs, that can assist us? Again, remember, we stratify our patients, we classify our patients. Any information on past or current care, failures or successes. Any unique circumstances about this particular patient that we may need to know. And as a physician, your prognosis on this patient. We seek to foster partnerships with providers in interdisciplinary collaboration. We are autonomous practitioners to be respected and valued as the team members that we are. We focus on person-centered care with our clients, assistance in discharge planning, because we know discharge starts from admission, and care coordination on the many needs a patient may have, the many resources or providers a patient may need. Effective, clear, and timely communication with the patient, family, and caregiver, because they are to be involved. They're the ones that live with the patients, and they're the ones that support the patients. And in some situations, certain home situations are actually counterproductive to a patient getting better. Decision support for team members, shared decision making with acceptance of the patient's voice in that decision, and clarity for the pathways for the health of that patient. So this presentation was sparked by the World PT Day that was September 8th annually, and this year's theme was low back pain. It's a day of professional promotion to highlight physio's role in health and well-being, improve public and professional profile, advocacy for the profession and its patients to governments and policymakers, and to recognize the impact that physiotherapists have on global health. Also, this presentation is a precursor to what is Physical Therapy Month in October. So October will be representing, and you may see a lot of things, whether in the media, social media, newspapers, with regards to the efforts and energies of the many qualified physiotherapists that we have on this island. So here's 10 reasons why you should choose PT. There's a holistic approach, comprehensive screening and assessments, evidence-informed clinical reasoning to solve your problems, focus on function and mobility. We have a diversity of tools in our toolbox, knowledge base and environments. We act as care liaisons, and we seek to communicate with providers to make sure that we get the best idea and picture on the individual patients we serve. Reflective and consistent feedback and accountability to improve the mental health and self-efficacy of the patients we serve. Individualized injury prevention and recovery, disability adaptation, so for where there may be a need for supports, being able to advise and coach patients along. We also look at patients across the lifespan, again, from the cradle to the grave. And a bonus, we have an impact on the overall healthcare cost when we look at having physio early and often in the beginning, compared to a patient being disabled and potentially having to have spinal surgery. These are the references for the presentation. And these are my contacts as far as Instagram, Facebook, and email. And if you need any more information regarding local physiotherapy, physiotherapists wanting to know whether someone's licensed or regulated in the country, you can reach out to us at the Bahamas Association of Physiotherapists or the Health Professions Council. Any questions? Thank you so much.
Good morning. Yes, I would like to say happy October and happy Physiotherapy Month. I truly enjoyed this presentation. A question I may have for you includes, are we having the necessary support to get more physiotherapists and other therapists in place for the onslaught that is to come with children being autistic, etc., and also having physical challenges and speech therapists, speech impairment. And so what do we have in place and how we should go about it? What is our vision for, let's say, 2050 in terms for this type of persons? I'll listen.
Woo! That's I had to let out a big old exhale on. Okay, so the question is a bit layered. Being the senior physiotherapist, your question has certain answers that are above my level, that may be a bit more at the executive level and my director. But I am aware that there are efforts being made to solicit and recruit therapists. However, in working in the public healthcare system, understanding the resource challenges, both human and literal, we know that we don't have control of the procurement of staff. We don't have the control, financial clearance and otherwise, for staff. So while we may say we need X amount of bodies to be able to meet the needs of the service, the decision on when and if that happens is not our own. And so conversations like this, advocacy like this from providers that refer to us and providers that they themselves has understood the delays in receiving care for their patients can help us advocate to the persons, the executives that make the decisions on hiring persons to meet those needs, for us to be able to prepare for as you mentioned, the onslaught. And especially since you talked about peds, that is a significantly underserved area right now where the specialists that we have may potentially be aging out. And so we currently have a difficulty even recruiting Bahamians within this service because right now, a number of our staff are expatriates where the Bahamian workers who may come into the service do not stay for longer than 3 years. So then we have to look at what package are we actually offering for persons to consider public health as a career. I hope I answered your question.
Okay, thank you. Thank you so much. I see we had a participant who was so excited and couldn't wait to ask that wonderful question that she jump-started our question section. Before we officially open our question section, I would just like to thank you, Ms. Newbold, for an absolutely wonderful, comprehensive, totally enjoyable presentation. You have addressed areas that I'm sure many of us may have not considered when it came to physiotherapy. You have definitely highlighted the importance of your role in medicine, and I definitely look forward to working with you so we can have a true integrated experience for our patients. You highlighted some very key words inclusive of your range of your services from the cradle to the grave. And, in family medicine, that's also the range of services that we offer as well. And you highlighted something very important: patient-centered care. And that is something that we all need to think about. And your role is very important in us being able to provide patient-centered care. Now, I see we have the chat that has gotten started. Please complete the CME feedback. It is located in the chat section. Also, for those who have signed on using your phone name or some other name, kindly change to your government certified name, the name that's on your BMC registration. Thank you. So we have comments. Excellent presentation. That is from Dr. Dean. Dr. Spencer Prince says, brilliant and well-executed presentation, Ms. Newbold. Dr. Randa Darville says, excellent presentation.
Thank you.
Okay, and we have Dr. Bodie, phenomenal presentation. I love these adjectives. Phenomenal presentation. Thank you. And Sheldon Prince, awesome work. Tira, I guess he know you. Well done.
Madam Chairman, can I ask another question, please?
Yes, you may go ahead.
Okay, so Ms. Newbold, in terms of physiotherapy, you have such a soothing voice. I wouldn't mind you being my therapist. That's a statement, but the question that I wanted to ask was, like, in terms of, let's say, patients needing surgery and therapy, are all of the surgeries validated? Is there a need for surgery in a lot of these cases, like you mentioned, spinal issues, etc.? And you mentioned working on therapy, the therapist working with those patients. Is there any other medications that they can take in order to not have surgery? That is, having surgery as the ultimate last resort. Maybe the physiotherapist treatment is enough for them and they can practice these things at home, because I'm sure you all teach them. We say in medicine, each one teach one, reach one, And so is surgery necessary for every type of physiotherapeutic injuries or any sort of assessments that may help or hinder the course? Thank you.
Well, I thank you for the question. I definitely want to make sure that the presentation didn't give the impression where I had post-operative rehabilitation that that surgery was not a last resort. Okay. When it comes to considerations for spine surgery, our surgeons, and I know the surgeon that I work with, I think he's on right now, that he has a conservative approach and will exhaust every and any effort with regards to management of repeated course or episodes and referrals to physiotherapy to assist patients in conservative non-operative management. Then you may have patients progress to the point of possibly, depending on their injury or issue, to pharmaceuticals that might include like epidurals. Okay. And so, yes, things like surgery are traditionally a last resort for patients. Because we know once you've done a surgery, it's a surgery. There's no reversal of the trauma that happens with a surgery. And then when you start to talk about the potentially the outcomes, each surgery has its own outcome. When you look at someone who may have a laminectomy compared to a fusion, compared to decompression, compared to another surgery. And those decisions are made by the surgeon, who may at times ask us as far as how did the patient fare with the rehabilitation, to assist in deciding on, is this person a surgical case now, potentially later, or not at all? All right. And that's where, again, the communication between the physiotherapist and the surgeon for those applicable patients comes in line.
If I may ask a question, good morning, everybody. This is Dr. Spencer Prince.
Hi, Misty.
Hi, Autira. I'm really, really, really excited because to be honest, I'll say it in this forum, physiotherapy was not highlighted justly in med school for me, okay? And because I associate with you and with physiotherapists, I have really grown in my appreciation as you are a professional group that complement the care of patients. My question is this. You mentioned that oftentimes when patients complain to their doctors of back pain, the tendency is to do an x-ray or do a CT scan, do an MRI, and then certain things are found and we send them for physio based on what is found. And I've heard from my husband oftentimes, that is not the cause of the person's back pain. Yes, this was an incidental finding, but that is not the it of their pain. Can you comment more on that, please? Because I think as physicians, we get very excited and motivated when we see pathology, but not all pathology may be related to what they're complaining of. Can you expand on that some more, please?
Most definitely. I appreciate the question, because a lot of times when a patient comes complaining of pain, routinely, a patient may be sent for an x-ray. And some instances, depending on the provider, they may be sent straight for an MRI. And as I would have mentioned earlier, the evidence states, and I would even echo that the doctors in clinic may say, we don't treat imaging per se, we treat patients. And so when we look at patients, when doctors do a diagnosis, they would have the imaging, they would have the subjective complaints, and we know that a lot of times you can have your deductive reasoning on what you think is going on with the patient just from a subjective history. With us in physiotherapy, a lot of our assessments are similar in the subjective history and the objective findings, but we also look, as I mentioned, on what level of potential disability or reduction in function that this patient may have. And from doing that, we come up with a clinical picture of care and management for this patient. These days, there's less reliance on the pathoanatomical model of there being a specific tissue or injury or lesion being the source of patient's pain, and more of a picture, as I mentioned, of a biopsychosocial approach. Let's say I had a patient that came in that had an injury on the job, history of back pain, right? However, there was a very strong emotional and psychological basis for her that we went through exercises, we went through coaching, we affirmed and dispelled certain beliefs and behaviors. We also challenged beyond what she may have thought she had the capacity to do, and she progressed very well. And when it comes to, and then to go back to the imaging, as I mentioned, you may have patients that the X-ray or MRI report may say degeneration, but some of these things are natural courses of aging, not necessarily pathology. The significance of those things may be found in how the patient reports as far as it affecting their disability or their function. And if you are questioning what you see, you refer it on to the tertiary level of potentially a spine specialist. So I would say that I do believe in some instances that we do send for x-rays a bit much as a first line before potentially sending for physiotherapy with patients.
Thank you, Autira. And one other question, a burning one. Chiropractic versus physiotherapy. Can you explore that some more? I have patients who go to the chiropractor. I am hesitant, to be honest, to refer to chiropractic, but I know physiotherapy and I know what you do from a personal level. Tell me where physiotherapy ends and chiropractic begins, if that's a good way of putting it.
Well, that's a frequent question, right? With regards to the difference between chiropractic and physiotherapy. As we would have it in 2024 compared to times past, there is almost a merging of professions in, I mentioned we're doing more manipulations that may have been chiropractic, but it's specific to what we identify in our evaluations that we identified as a need for something that we're doing on the patient at that time. Whereas chiropractic, it is an actual practice and treatment method, oftentimes every session. So let's say you may purchase 12 sessions. Every session, you will more than likely get a manipulation with the idea that this is to help mobilize your nervous system, in the idea that the spine is the source or the root of everything. And so by loosening up the spine, the nerves will in turn function properly. One of the challenges that I have is that it's a passive approach. And as I mentioned before, with manual therapy, patients love it. They hear something crack and they feel like something's going on. And in some instances, yes, it is, if it's applied appropriately for the right patient, the right time, the right condition. If it's applied incorrectly for the wrong patients, let's say potentially someone with a spinal instability, someone that has potentially a degenerative spondylolisthesis, you can actually promote further instability and potential nerve and cord compression for patients. And I have seen those patients in clinic. So there are applications for both. It's just making sure that the consumer understands that physiotherapy offers an active approach, a partnership approach, and a reasoned approach for every treatment session. We do not solely rely on tools or tricks of the trade to say get you better, but we use them as adjuncts based on what we see are the needs of the patient at the time. So your treatment sessions may change from one session to the next. It rarely may be routine. I hope I answered your question.
Thank you. Thank you so much, Ms. Newbold. I see we could go on and on and on. That is a testament to how exciting your presentation was and how much information people still want. And so we hope that you would accept our future presentations, our future invitations for additional presentations. Just before we wrap it up,
Madam Chair, sorry, my bad. I was just wanted to make a quick comment, if I may.
Dr. Grimes.
Okay, hey, I want to echo what everyone's saying. This excellent presentation. I had the pleasure of working with Ms. Newbold. She was started a program where we had inpatient physiotherapists to our spine clinic, and has been an indispensable resource, and has now we have some of our colleagues rotating through since she's moved on to bigger and better things. But what I would say is that, you know, she hit on a nail on the head in terms of the conservative approach that we have with reference to surgery. There are hard indications for surgery that are required in terms of if there's spinal cord compression, neural compression causing disability that need to be addressed. But typically with the most common complaints in terms of degenerative complaints and so on, we take a very conservative approach. Again, because our waiting list and their waiting list is long, typically people have to go through that. And then to answer the question of chiropractor, you know, I think she did an excellent job doing that. What I would say is that the early treatments of manipulation and so on and so forth are kind of not not dissimilar from the results of therapy, but the long-term results of therapy are superior in terms of lower risk of recurrence and so on and so forth. So, hence you govern yourself accordingly.
Thank you, Dr. Grimes. And one last thing, Ms. Newbold, I see where we have people asking for your presentation. They would like access to your presentation, your references. One last thing, you mentioned the importance of early intervention. And as a family physician, that's definitely something that we like to adhere to as best as possible. However, you also recognize that you are currently limited in the amount of physiotherapists that you have to offer service. So when we do get those patients who come in complaining of low back pain, and we get them a whole lot, as you can imagine, and we would like to offer early intervention, with the limitation that we currently experience at our institution, how would you best advise?
Boy, y'all putting my feet to the fire today. I would say that there are some facility restructuring that we have to do, right? And one of the things that can be done is we have some patient education handouts that we've been utilizing in clinic, that we may share those with the family medicine persons to be able to use. Having been on this presentation for those that had the ability to attend, being able to stratify and have an understanding of the best use case for those handouts and patient education material. As far as our service, we really, at this point, with the staff that we have, are going to have to figure out how to operate differently. And that may mean things like shortening our treatment times with patients, whether it is the session itself or potentially the entire episode, putting more responsibility on the patient with regards to, as I mentioned, directing them to community resources, as well as being able to purchase supplies. Like, it's not uncommon for me to tell a patient to go and buy kinesio tape, and I tape them, or to send them to buy a TENS machine, or to buy a hot pack or a cold pack. Another thing could be for those physicians to be able to assist us in not repeat referring patients who are non-compliant with advice and instruction. I understand that those patients may have flares, but we also have a number of patients that need the service, and there are patients that are non-compliant and want us to do it for them and have not entirely accepted, when you think about behavior change, have not entirely accepted their role in their own recovery. So that can help make some space for some patients as well. Because as soon as we stop with one patient, about a month later, we get a referral back for the same patient. And that happens more often than not.
Okay, thank you very much, Ms. Newbold. Our time has quickly slipped away from us. Ms. Newbold, would you be so kind as to make your presentation available to those who are asking? She has agreed. She has also given us her contacts that she can be reached should you have additional comments or you have additional questions. I'm quite sure that she will be more than happy to answer them for you. So again, thank you, Ms. Newbold, for taking the time out to come and share your extensive knowledge of how to treat and manage low back pain and the role of physiotherapy in making that happen. And a special thank you to all of you participants who came, who listened attentively, who asked questions, gave comments, and The majority of you remain on the session for the entire presentation and question and answer period. So I am so proud of you. We look forward to seeing you again at our next session of our CME, which will be the second Wednesday of October. So until then, take care of yourself, use the knowledge that you've learned, and let's go out there and be the best healthcare provider we can be for our patients. Have a great day.